Well, thank you, Mrs. and Mr. Chairman, for the kind invitation and introduction, and thank you for the kind invitation to come here and for the opportunity to share my experience with CytoSorb in a clinical scenario. In particular, I'm going to focus on ECMO patients. This is my conflicts of interest, and in order to dive into the theme, I would like to take you on a nightmare journey as it might clinically happen everywhere. This was the story of a young man who had rectum resection due to carcinoma. He was readmitted due to intestinal obstruction, and surgical therapy was indicated. So far, so good. But then, with anesthesia induction, it happened that the patient aspirated during anesthesia induction. Bronchoscopy was performed, well, not so bad. So colleagues decided to continue with surgery, which lasted 4 hours. And the problem was that the patient deteriorated with his respiratory function during the procedure and had to go on VV ECMO at last. This was the first picture when the patient was admitted to the ICU, and there we had to switch the ECMO from VV to V8 due to right heart failure. The patient had one of the most severe ARDS with massive alveolar edema I've ever seen, developed multiple organ failure, acute kidney injury, went on CRT, had severe systemic vasoplegia, massive capillary leaks, and a few hours later this was the X-ray and the corresponding CT scan. And now if in this situation, if you calculate if this patient is going to survive or not, you could take the SOFA score. This patient had 22 of 24 SOFA points, and the probability of this patient to die was reasonably high. So in this situation, it's a Hamlet dilemma, to be or not to be, or what else could you do? If we look at the lab chemistry in this patient, we had the interesting thing that this patient had normal leukocytes in the beginning, and after admission to the ICU, there was a steep decrease of leukocytes. And we looked on the cytokines, and this patient has sky-high rocketed interleukins, as shown with IL-6, IL-8, and PCT. They all had left the measurable range, and we are talking in this situation what we heard from Patrick Honoré about the cytokine storm. So we went on with treatment, had to perform bronchoscopies. You can see this massive alveolar edema. The patient was in ECMO. If we tried to use protective ventilation, antibiotics, kinetic positioning, renal replacement therapy. And then the question is now, would you, and everybody may decide on his own, would you think that there is a reasonable rationale to use hemoadsorption or cytokine absorption in this patient? I think we're talking about a patient who is going to die, yes or no, to be or not to be. That's the question. We're very desperate, and everybody may decide on his own. That brings us to the underlying problem in this context, and that is the inflammation. In ECMO patients, we have two sides of inflammation. The one is the underlying disease. So in this patient, it was clearly the aspiration and the pulmonary inflammation, but we also have per se, due to ECMO treatment, I will show that later on, an inflammatory stimulation. And that brings us back to what Patrick Honoré already has introduced, to the story of sepsis, to the dysregulated host response with pro- and anti-inflammation. And what we do know that the pro-inflammatory response, if exaggerated, may cause additional tissue damage. And this is what actually the peak of cytokines, these are probably the problems, this kind of mediator tsunami that causes and that triggers multiple organ failure. And we know from John Callum's data that the higher the inflammatory response, the higher IL-10 and IL-6, the higher the mortality risk. That's nothing new, really. And what are the effects of the interleukins? This is probably one major effect, is the effect of interleukins on degradation of capillary integrity, and that leads to capillary leakage, tissue edema, hypoxia, necrosis, and That means that indeed cytokine absorption or the control of this cytokine storm may be a valuable target in this situation. And we know from another paper that this degradation of endothelial integrity is one major point, and you may all agree that in patients who are on ECMO, they usually have massive capillary edema, massive capillary leakage, and we are trying to seek approaches to reduce vascular leakage. And the other point, as I told you, is that ECMO per se may cause inflammatory response due to complement activation, due to activation of anaphylactic toxins, due to coagulation pathway activation and formation of cytokines and neutrophil activation, which per se may again end up with organ damage. So we are treating a situation with a measure that per se may aggravating this development in terms of inflammatory response. So the question is, how could we address and solve it? And we heard from Patrick Gonorrhea that actually the story is as old as chemotherapy is, that we try to purify the blood from whatever mediators, and we try to cut the upper limit of this mediator response in order to get control about this out-of-range inflammatory reaction. And there were several measures mainly linked to renal replacement therapy, but a new one is hemoadsorption. Again, we are talking about this middle molecule range where all these pro and anti-inflammatory mediators are located. The cytokinetic model was already introduced by Patrick Honoré, and I want to briefly just go through it, and that's just like a flashback, because I think that's a good rationale. Why should we reduce cytokine levels? The one is to re-establish the gradient from the tissue to the blood, or from the blood to the tissue, and enabling the immunocompetent cells to redirect where they need to work. This may be a bit different in ECMO patients because I have a kind of global inflammation, so that might not work out in this patient. I'm going to show you later on. So is hemoadsorption the right therapeutic approach in this circumstance? And what we use as a cytokine absorber, and which is registered in Europe since 5 or 6 years now, shows in animal experiments that it's able to reduce cytokine levels, and by that again reduce further cytokine production. What makes it attractive for us as clinicians that we can hook it up, as you see here, in a CRT circuit. You don't need any specific machine, and if you can hook it up to a CRT circuit, you theoretically can add in an ECMO circuit as well. And we heard about the safety, about the high compatibility that was reported so far with no serious adverse events. And the approach in this context is not a specific endotoxin or anti-TNF or approach eliminating such a substance, but we have a roughly broad approach, eliminating cytokines, trigger substances. We heard about the DAMs and the PAMs. I don't want to go into detail, and even toxins in this context. And that maybe that makes it attractive in many clinical situations, because usually I don't know, is it gram-negative or gram-positive, or what kind of infection it, or is it anyway a bacterial or fungal infection. And that it works to reduce cytokines in this setup shows we used a cytokine absorber in a cardiopulmonary bypass with pretty high flow of roughly 350 ml per minute, measured pre and post absorber, and yes, it does what it's supposed to do. So that's just a proof of principle. Yes, the cytokines can be reduced via the absorber. So from theory, we come now to practice. So that's a real question. What are the clinical experiences? Do we have clinical data that cytokine storm control with blood purification, with hemoadsorption is effective, and is effective during ECMO therapy as well? No. We started treatment in 2013, and in the meantime, we have treated almost 170 patients in several indications. The main group, I'm working on a cardiosurgical unit, is patients during bypass, but I'm now going to skip all these other indications, and I'm going to focus on this small segment of ECMO and ECLS patients. And that brings me back to the patient I started with, because yes, we decided to use hemoadsorption in this patient as well. And what we could observe was we had 3 cytokine treatments in a row. And please note that this is a logarithmic scale. So you see here the cytokine levels for IL-6 and IL-8. And well, we could decrease the levels. But one thing which is important, we could decrease it, but we did not completely eliminate these substances. So the adsorption and the elimination is actually linked to the concentration. And actually, we don't want to eliminate it completely, because I think this pro-inflammatory makes sense to a specific extent. And that is what you can see. But that's, again, just the adsorber does what it's supposed to do. But what were the clinical effects? The clinical effects were that these patients, we had here pretty high noradrenaline levels. With the start of the second treatment, we could reduce it and almost wean the patient from the catecholamines. So that is one main phenomenon when we are treating this patient. And again, if we look at the balances in this patient, we can see that during the first day, the patient had massive capillary leakage, massive positive balances. And with the third treatment, we started to gain an equilibrated or even a negative balance. So that may also have an impact on the endothelial integrity. And well, we were lucky, the patient were lucky, we all were happy the patient finally survived. So now, if we go into the literature, there are several reports, and the first one was from Frank Brünger from Germany, who investigated the patient and used cytokine adsorber during ECMO treatment. But he used it in a way that it was linked to the CRT machine. Is it possible to also link the hemoadsorption therapy to an ECMO circuit? Well, it is, and this is one case we saw a couple of time ago. This was a patient who came with acute febrile disease with pulmonary failure, went on VV ECMO. This patient had a long history of cardiac surgery with aortic mitral valve repair and so on. But the point was this patient presented with a clinical picture of septic shock, but the patient did not develop acute kidney or a high-grade acute kidney injury, so we had no indication to put this patient on a CRT. And the question is, could we integrate a CytoSorb therapy in ECMO circuit? Yes, we did, but that was actually the job of the perfusionists. So they know how to do it, and I think it's a safety issue. I wouldn't recommend for everybody now just to hook it up in some way. There are now commercially available connectors for ECMO ECLS systems, and they will guide and help you to get that fixed, how to integrate a CytoSorb adsorber, because there are, of course, some apparent problems. You have a flow limitation, so you must not put it in the normal line. You have to integrate in a parallel line. You have the danger of disconnection if you are working with three-way stopcocks and so on, and it has to be practicable for everybody. And I think safety is an important point, and therefore I want to give the technical caution that if we integrate it into ECMO circuit, we should use this specifically designed tubes in this patient. How did it work out in this patient? This patient came with high PCT, high CRP, and we performed one CytoSorb treatment over 24 hours, and indeed in this patient we had a steep decrease of IL-6 and IL-8. Again, it worked, and this was associated with a clear clinical amelioration of the patient. He had only one treatment course over 24 hours, and after day 5 he could be weaned off ECMO and retransferred after 2 more days to a referring hospital. So the pattern, how patients react clinically on hemoadsorption is roughly the same, be it in ECMO patients, in septic patients, in patients with post-bypass SEERs, which we see every once in a while. We see decreased cytokine levels. Well, that's I would expect that. But what we see clinically is that we see positive hemodynamic effects. So patients need less vasopressors, less catecholamine need, and we see a metabolic stabilization, so decreasing lactate, normalizing pH. So these are the obvious clinical signs for us. So I put the experience of 20 ECMO patients together, and here you can see that it holds true for these patients as well. This was the first treatment in the patients, because in ECMO patients, if you're treating the patients for 7 or 70 days or so, you probably won't put them on an adsorber for this time frame. So with the first treatment, you usually the most pronounced reaction. And what you see here is a decline in IL-6 and a decline also not that obvious in the IL-8. And the question again is this reduced cytokine level linked to hemodynamic stabilization? And what you can see here is the mean arterial pressure during the CytoSorb treatment. And what we can see, and it holds true for almost any other patient group we are treating with this approach, that we have a reduction in catecholamine need. You see here the noradrenaline dose going down during this one-day treatment. And metabolic stabilization as well. You can see the increased lactate levels, and with hemodynamic stabilization, again, we see lactate normalization and normalization of basic SAS or pH, whatever you may take. Well, so it's really the same pattern as we used to see it and learned it from other patients. But there is another point if you're talking about patients on ECMO, and Dr. De Gasperi already focused on a very specific point, because if we take the cartridges, rinse it with saline, after the treatment, you see red, green, brown, any color. So we are obviously attracting pigments as well, and one is indeed bilirubin, but there is also other pigments which play a major role in these ECMO patients. This is free hemoglobin, which ranges from 32 as a dimer or the tetramer from 65 kilodalton, and this may be adsorbed as well. And as we know that the free hemoglobin is not merely innocent bystander, but it may be a substance that per se may trigger several negative effects, like increased mortality in a LPS model, vasoconstriction, thrombocyte activation, endothelial dysfunction, increased mortality. And I think all this criteria make sense that the hemoglobin usually is in the erythrocyte and is supposed to be there. So can we, and in ECMO patients, hemolysis may be often due to technical problems, a serious problem. And in this patient, we had severe hemolysis because this patient not only was an ECMO, but he had mass transfusion as well. So he had really severe and increased levels of free hemoglobin. And you see that we put him on a sequential roll of 4 treatments, and by that we could decrease the free hemoglobin. And this is, if I take all the patients, you can see this reaction pretty well, that this decrease during the treatment can be observed in the group of these 20 patients. And the same holds true, and we learned that from Dr. Gasperi's word. And again, this is just a single case, a patient who was on ECMO due to hemolysis. He developed icterus, hyperbilirubinemia. And again, we put him on an adsorber. And as you can see, with several consecutive treatment, that we could reduce the bilirubin reasonably. Also, during the first treatment for all these patients, this effect is not that clear, but that's a regular phenomenon. We can observe that patients with increased bilirubin may also profit from this adsorptive effect. So the question is now, these are what clinical endpoints and clinical observations. The question is, what do we actually go for? What are our goals or targets when we are treating? And I hit into an acronym called SHINE, as shock-induced endotheliopathy, from Johansson in this very recent paper. And they describe that due to shock, vasopressors or catecholamines, we have an endothelial activation and several severity grades of endothelial damage, which may finally lead to capillary leakage. And in particular, during ECMO, we often have this phenomenon of capillary leakage. So the question is it a reasonable approach also to cope with this problem? And there was an interesting in vitro study, though, this year from a German work group from Hannover, and they investigated how blood from septic patient acts on an endothelial monolayer. And what they could observe, that if we have a disrupted endothelial monolayer, if the blood from septic patient is put on this layer. And they took a second step and treated this blood with hemoadsorption. And after hemoadsorption, you can observe that capillary leak was, controlled. So indeed, controlling the pro-inflammatory cytokine levels might end up with an, better endothelial function, and the authors concluded that there is potential protective effect of cytokine removal on vascular barrier function. And there is a second point, and it's a very recent paper also from John Callum's group. They investigated the resistine, and in sepsis, acute kidney injury, and probably also in ECMO patients, resistine or hyperresistinemia, which resistine is a pro-inflammatory cytokine, may play a role, because they described that resistine is actually active in, disabling neutrophils to do their job, phagocytosis and so on. And what they could show, that with hemoadsorption it was possible to reduce resistine levels. And what resistine causes is a higher colony-forming unit. So the Pseudomonas starts to grow when the neutrophils are inhibited by resistine. And after using hemoadsorption, this ability of neutrophils to again work as phagocytes was reestablished. So they concluded that hemoadsorption not only corrects this kind of hyperresistinemia and restores neutrophil dysfunction, and may by that also be a point as to have it as a therapeutic option to alleviate immunosuppression. And what we see in the long term in septic patients, sometimes it's a problem of immunosuppression, that the patient cannot cope again with infectious diseases. So to conclude, we see reduction of cytokine levels with this treatment option. We see mitigated cytokine storm. We see a maintained immune response and a faster hemodynamic and metabolic stabilization. If it's going to work out as a decreased capillary leak, better organ recovery, or even outcome, I think these questions are still open, but I think we will see in the future. And now at the very end, you might ask, what about the evidence? And indeed, is there an evidence? If you look into the holy grail of ECMO therapy, the also Red Book, you are not going to find something about hemoadsorption. And if you go to the sepsis guidelines, it's almost the same. We make no recommendation on the use of blood purification, but further research is needed to clarify the clinical benefits. And I take the sentence Patrick Honoris, we are seeking, we have not yet found the truth, but we are seeking for the truth. So we are still in a very early phase, but we are on the way and we are looking for it. And how are we going to look for it? and this was introduced as well. We are using a registry where we try worldwide. In the meantime, we have 147 centers included worldwide to register patients who were treated with CytoSorb, and you see the increasing number. And earlier this month, there was the first publication of interim analysis. However, if we get big numbers in ECMO patients, I don't know, because this mainly focuses on patients with septic shock, on patients with cardiac surgery, post-operative cardiac surgery. So the ECMO patients probably will go into these other indications. So we will see in the future what the results will be. And if you're lacking evidence, you might also have the opportunity to ask your intensivist or to ask yourself. And that actually was what the registry did, just to ask the gut feeling of the intensivist. Did you have the impression that it helped? Did the condition of your patient improve on the CytoSorb therapy? And there were at least 2/3 who said that very much, or minimally. And there was only 1/3 who say, well, there was no change. But indeed, there were no comments that the patient worsened during this therapy. So not the proof, but maybe a signal. We will follow it. So to end up, I think we have a new piece of a puzzle in the whole treatment of our sickest patients. And I think we all agree that the ECMO patients are one of our sickest patients. And the future is going to show us what potential hemoadsorption will give us. And we are still on a long way to seek the truth. Thank you.
Karl, we have very few seconds before we close the session, but I would like to point out and you to comment on the fact that we cannot give recommendation for the use of blood purification in sepsis doesn't mean that we recommend not to use.
Okay.
Can you comment on this? I mean, do you have a specific idea on what would be the next step?
Well, I think that's completely true, but a lot of people are saying, well, there is no recommendation, therefore I must not use it. So I think it allows us to use in very desperate situations if there is a good rationale. And right. I think that's an important point. We have to identify the patients who are going to profit from this kind of therapy. So these are the very immunologically overstimulated patient, and I think there we have a good rationale, and we might have an option, and maybe we can collect data with that it works in this specific patient, but probably not really for everyone. Yeah.
Thank you, Marley.
Thank you very much. This has truly been a very exciting lunchtime meeting. I think the future is very bright, and I look forward to more presentations, more data. I hope that Professor Ronco invites the various speakers to his famous international CRRT meeting where blood purification is a common theme. So I think it's truly been very exciting, and I certainly have learned a lot. I'd like to thank the speakers for a fantastic presentation, and I'd like to thank CytoSorbents for sponsoring the day. Thank you.
Thank you.